Hello everyone, my name is Eloi Gergelé. I'm a French physical therapist. I am in the last year of my manual therapy fellowship program at the University of Lille, France. I am currently doing a clinical rotation here at the Advanced Physical Therapy of Anchorage, Alaska, with the International Academy of Orthopedic Medicine. I am working with Dr. Phelps, Dr. Maori and their colleagues, and today I have the immense pleasure to do this presentation on temporomandibular disorders from a physical therapy perspective. So I'm going to begin with an introduction, then we are going to look at the evaluation, and we are going to finish with the treatment options. So first of all, the TMJ, or temporomandibular joint, is a joint between the temporal bone and the mandible. So you can see it just here. It's a bicondylar joint with cartilage here and here, synovial cavity, and an articular disc. We have 4 masticatory muscles, and I'm going to describe them from the outside to the inside. The first one is masseter. It goes from the zygomatic arch to the lateral angle of the mandible, and it does some elevation and protrusion, which means that it's going to close the mouth and pull it forward. The next one is the temporalis. It goes from the temporal fossa to the coronoid process of the mandible, and it does some elevation and retraction, which means that it's going to close the mouth and pull it backward, pull the mandible backward. Then we have the lateral pterygoid, which goes from the sphenoid to the condylar process of the mandible and the disc, and it does some protrusion and depression, which means that it's going to pull it forward, pull the mandible forward, and help to open the mouth. And finally, we have the medial pterygoid, which goes from the sphenoid to the medial angle of the mandible, and it does elevation and protrusion. So now let's define TMD. So temporomandibular disorders are a group of more than 30 conditions that cause pain and dysfunction in the jaw joint and muscles that control jaw movement. It's a definition, we can find others. And thankfully, in 2014, have been published the diagnosis criteria for temporomandibular disorders. They did a fantastic job on describing how to assess patients with that kind of disorders and how to diagnose them. These criteria are presented in 2 axes. The first axis is the biomedical part, and the second axis is everything around it, like the function, the psychosocial status, and everything. We're going to see that later. A little bit of epidemiology. So TMD has a high prevalence because it has been estimated that 35% of the population has TMJ symptoms, TMD symptoms, but only 5 to 10% of the population is going to seek treatment. The 4 main risk factors are bruxism, being a woman, having an age between 20 and 40 years old, and having psychosocial troubles. Now let's move on the evaluation. We're going to begin with the complaints observation, And first of all, we will make sure that it's a safe treatment that we're going to deliver. So we need to screen for red flags. I like the VIT and VIT process of screening to be able to screen for every kind of condition. So we're going to look for visceral disorders, infection, tumor, neurological disease, vascular disorders, inflammatory disorders, and finally trauma event. I'm not going to go too much into this topic because it would be the topic of a whole presentation. So then, still in the complaints observation, we are going to look at axis 1, so the biomedical diagnosis. We have two questionnaires that we can use. The first one is TMD screening questionnaire. It's a questionnaire, a short questionnaire that you can send to your patient in order to screen for TMD symptoms. And if the patient is above the cutoff, you can consider that the patient probably has a TMD, so you can investigate more on this topic. So then you have the symptom questionnaire, which is a questionnaire on the patient's symptoms, and 4 main questions are asked in this questionnaire. So where is the pain? Does the movement modify the jaw movement modify the symptoms? Is there any noise, and is there any locking history? And it's going to help us to make the good diagnosis. Then we have axis 2, and we have several questionnaires and paper work for the patient. The first one is the pain drawing part. The patient has to draw his pain on a body chart. Then we have the pain scale to rate the pain intensity. We have the jaw function limitation scale in order to assess the patient's function. We have the PHQ-4, which is a short version of a questionnaire to assess the psychosocial status. And finally, we have the oral behavior checklist in order to assess the load that the patient is having on his jaw based on the day-to-day behaviors. So now let's see the physical examination, which is pretty standard. We are going to begin with a static observation in order to confirm the pain location with the patient. Then we are going to look at the global posture, and especially the mandible posture compared to the maxillar part. Then we are going to do dynamic observations. We are going to look at the opening pattern and look for any deviation from the sagittal plan. And if we find any deviation, we are going to record if the deviation is corrected or not, which means that we are going to record if at the end of the movement the patient is coming back in the sagittal plan or not. Then we have the range of motion that we are going to record in different manner. The first one is the pain-free range of motion. Then we have the maximal range of motion, and we are going to finish with the assisted maximal range of motion with the help of the examiner. And each time we are going to look for pain and noises. We are going to do the same thing for lateral and protrusive movement and record for the range of motion, the pain and eventual noises. And finally, we are going to palpate the muscles and the TMJ in order to confirm that we are able to reproduce the patient's main complaint. This is short examination, and we can add other tests, especially on the cervical spine. So now let's have a look on the main diagnosis that you can find for your patients. In this table you have the three main diagnoses that you can find which are pain related. So the first one is myalgia. So to make this diagnosis, the patient has to report pain in the jaw, temple or ear area, and he has to report that this pain is jaw movement related. During the physical examination, we are going to confirm that the pain is in the masseter or temporalis area, and we have to reproduce the familiar pain with palpation or mouth opening. Then we have arthralgia. The patient has to report that he has pain in the jaw, temple or ear area. It has to be jaw movement related, and we are going to confirm that with the pain location on the TMJ, and we are going also to confirm that we are able to reproduce the familiar pain with palpation, opening, lateral or protrusive movements. And finally, we have headaches caused by TMD. In order to do this diagnosis, the patient has to have a diagnosis of myalgia or arthralgia, and the pain has to be in the, the headache has to be in the temple area, and it has to be jaw movement related. In the physical examination, we are going to confirm that the pain is located in the temporalis area, and the familiar pain has to be reproduced with palpation, opening, lateral or protrusive movements. So these are the main diagnoses that you can have for the patients that you're going to see with only pain in this area. Now we are going to look at the main diagnoses, which are TMJ related, and in this case you can have a locking history or a noise history. First diagnosis is subluxation. It's only based on the history taking. The patient has to have an history of locking in an open mouth position in the last 30 days, and the patient needs to do a self-maneuver to relocate the jaw in its position to confirm the diagnosis. In the case that the patient comes to the clinic with a locking in an open mouth position and the practitioner has to relocate the jaw, it's considered as a true luxation. Then we have the degenerative joint disease. During the history taking, the patient has to report noise in the last 30 days or noise during the physical examination. To confirm that during the physical examination, we have to palpate crepitus during the jaw movements. We can use also auscultation to confirm that. Then we have disc displacement with reduction and disc displacement without reduction. Before talking about the diagnosis criteria, I'm going to do a short explanation on that. So it's possible that the patient has a disc displacement, which means that the disc is going to move forward from its original position and it's going to stay like that. And when the patient is going to open the mouth, the disc is going to relocate or not. If the disc relocates in its position, like in a backward position, we can hear a click, so it would be a disc displacement with reduction. But if the disc doesn't come back to its original place, it would be a disc displacement without reduction, and most of the time we don't hear any noise in that kind of patient. So for this displacement with reduction, so the patient has to have noise history in the last 30 days, or he has to report noises during the physical examination. And we as therapists, we have to confirm that with a click during opening and closing, or a click during opening or closing, and during lateral or protrusive movement. For this displacement without reduction, the patient has to have a locking history in a closed position. So it's explained by the disc that doesn't come back, and it has to be the patient has to have a limitation in the eating capacity. During the physical examination, we are just going to record the maximum mouth opening to state if it's a disc displacement without reduction with limited opening or without limited opening. As you can see, especially on the three diagnoses here, the metrology is lower, so sensitivity and specificity are lower, and most of the time all these three diagnoses has to be confirmed with imagery. So let's finish with the treatment options. To our knowledge, we don't have any real guidelines on how to treat these patients in physical therapy. However, the APTA is currently working on that, so we are looking forward to have these guidelines. We have, however, some systematic reviews on the topic that show with very low to moderate evidence the benefits of physical therapy. For example, we have evidence for soft tissue techniques like friction and stretching on the jaw and on the neck. We have evidence for the mobilization of the TMJ and mobilization and manipulation of the neck. We have evidence for education of the patient on motor control, strengthening of the tongue, the jaw, the neck and shoulder. We have also evidence on postural training for the jaw, but also for the neck, shoulder and thorax. We have evidence for breathing and relaxation techniques and for self-stretching. So as you can see, we have some evidence for treating the jaw, but we also have evidence to treat the neck, the thorax and the shoulder, because it has been shown that if the patient adopts that kind of position, it's going to put tension in the hyoid muscles, and the patient is going to open his mouth, and to keep it closed, he's going to activate his masticatory muscles, and EMG has shown that the forward head position is going to increase the tension in that kind of muscle. So evidence for the jaw treatment, but also on the neck treatment. We have evidence to decrease pain, increase the pain pressure threshold, to increase range of motion and function. So let me now do a quick recap for our patients, like few tips that they can use. So the first one would be to keep a chin tuck position to reduce tension in this area. Keep the front part of your tongue on the roof of the mouth. It's also a good strategy to decrease masticatory muscle tension, and we have to let a space between the teeth in order to decrease masticatory muscle activation. I would also recommend to relax, breathe out, and use different techniques of relaxation or hypnosis. You can also reduce the overload by avoiding some unnecessary habits like chewing a pen or using your hand in order to hold your head. You can do self-massage on the jaw and neck muscle, and also gently stretch your jaw and neck muscles. So these are my references for this presentation. Thank you so much for this attention, for your attention, and we're going to look at now some demonstrations. So now we are going to see soft tissue techniques for patients with myalgia. First of all, we would like to make sure that the patient is in a relaxed position. We are going to ask the patient to relax. I'm going to work first on the temporalis muscle. So it goes from the temporal fossa to the coronoid process of the mandible. And to be sure that I'm on the good muscle, I'm going to ask my patient to clench, and I can feel a contraction. Then I'm going to look for a tender or a painful spot, and when my patient tells me that he is having pain in a specific area, I'm going to work on it. So I can do transverse friction like that, or I can work also on a longitudinal way by following the muscle's fibers, or I can stay on the spot and work like that, doing circular movements. I can do the same thing on the masseter, so I can look for the masseter by looking to this muscle which goes from the zygomatic arch to the lateral angle of the mandible. And to confirm that I'm on the good muscle, I'm going to ask my patient to clench again and relax. Okay, and then I'm looking for a painful spot, and we are going to find the spot by looking for feedbacks with my patient, and then we're going to do transverse frictions or longitudinal frictions or stretching, or circular movements on the muscle. We would recommend to work on each muscle for 3 minutes, and we are always looking for monitoring the patient's symptoms. Okay, so now I'm going to show a hold and relax technique. So first of all, I'm going to explain my patient what I am going to do. So we are going to open your mouth together. I'm going to put my thumb on your lower teeth, and we are going to open your mouth. I'm going to ask you to clench a little bit and then relax, and then we're going to stretch together. We will not be able to communicate, so if you have anything, just show me your hand. I'm going to stop the technique. Okay, so open your mouth. I'm going to put my thumb on the lower teeth. Then we are going to open together the mouth. Perfect. And now try to close a little bit your mouth, just gently, and relax. And let me stretch a little bit more. So I'm trying to open a little bit more. Okay, then I'm going to ask my patient to hold 6 seconds again. Try to close your mouth and relax. I feel that he totally relaxed, and then I can add a new stretch. and then we're going to come back. So this is a good technique if you feel that your patient is restricted in mouth opening with muscle guarding, or if you want to decrease masticatory muscle tension. So the next technique is a joint technique. We are going to do oscillatory movement on the TMJ. So first I'm going to see where is the condylar process of the mandible. So I think it's here, but I'm going to check it by asking the patient to open and close the mouth so I can feel the condylar process moving and relax. Then I'm going to put my thumbs just here, and I'm going to do accessory muscle. So I'm going to push in the medial direction, and I can do different grades of mobilization depending on the patient's symptoms. And usually we can do several sets between 30 seconds to 2 minutes. Okay, so the next technique is a motor control technique in order to help my patient to keep an opening pattern in the sagittal plane. I'm going to give him some feedbacks with my hands and eventually with a mirror. So I'm going to put my hands on the mandible, and I'm going to ask my patient to open and close the mouth. And with my hands, I'm going to help him to stay in the sagittal plane. In addition, during the movement, I can add some caudal and forward glide and stay like that. It could help to reduce the pain during the mouth opening process.